người ta đã chiết xuất ra cái PDRN có nguồn gốc từ nho thanh rồi và đã được FDA approve từ rất lâu rồi. Và tiếp theo nữa là gần đây thì PN và PDRN tiếp tục được chiết xuất từ những cái nguồn thiên nhiên, đấy là trong tinh trùng của con cá hồi người ta phát hiện ra có cái sự tồn tại của nó. Và hai cái tính chất hai cái điều quan trọng nhất, một là chiết xuất từ thiên nhiên, thứ hai nữa là PDRN đã từng được FDA approve, cho nên từ những năm 90, cho nên là đây không phải là cái gì đấy quá lớn, quá lạ. Thế thì cái điểm nhấn thứ hai trong các cái sản phẩm mà có chứa PN hoặc là PDRN đấy là về mặt cấu trúc. Thì như tôi nói ở hai cái slide ban đầu về cái quá trình liền thương và cái quá trình chống lão hóa, thì tất cả các loại tế bào, thậm chí là các cái vi sinh vật, nó sẽ được tồn tại và tái tạo hoạt động tốt nhất khi mà có các cái giá thể nâng đỡ phù hợp, giúp cho cái quá trình hoạt động của các tế bào trong điều kiện tốt nhất. Nếu như chỉ có điều kiện cung cấp độ ẩm hoặc dưỡng chất đơn thuần thì cũng có thể giúp cho tế bào phát triển, nhưng sẽ là lý tưởng nếu như đủ độ ẩm, đủ dưỡng chất và có các cái giá nâng đỡ phù hợp, giúp quá trình tái tạo tổ chức đấy diễn ra một cách thuận lợi và sinh lý nhất, giống như cái cấu trúc trung bì mà tôi nói ở bên trên đối với người bình thường, đối với cấu trúc da bình thường. Thì trong cái phần báo cáo của bác sĩ Vân và báo cáo của Dr. Kim, chắc chúng ta sẽ để hiểu chi tiết hơn về cái hoạt chất này PN và PDRN. Thế thì về phần trình bày của tôi thì tôi chỉ nhấn mạnh vào hai cái ý lớn. Một là không phải cái gì mới, thứ hai nó đã từng được FDA approve, và thứ ba là nguồn gốc thiên nhiên. Và cái quan trọng nhất là không chỉ đơn thuần là một dưỡng chất, mà nó còn cung cấp cái giá đỡ cho cái sự phát triển và hoạt động của các cái tế bào trong cái điều kiện tốt nhất. Thì về mặt ứng dụng cũng như là chi tiết về mặt cơ chế thì trước đến phần tôi nghĩ trong báo cáo của bác sĩ Vân cũng như là của Dr. Kim chúng ta sẽ hiểu hơn về cái này. Ở đây là một vài những cái ví dụ về việc ứng dụng của PN và PN trong cái lâm sàng. Thì sử dụng đường tiêm, đúng không ạ? Đường tiêm trung bì đối với cái nhóm chỉ định ở đây là bệnh nhân bị đỏ da, đúng không? Thế thì chúng ta thấy rằng là đối với bệnh nhân bị đỏ da thì trước khi điều trị và sau 4 tuần điều trị thì cái việc cải thiện rất là tốt, đúng không? Rồi việc tái tạo các cái tổ chức, ví dụ như là chúng ta biết sẹo là một trong những cái rối loạn rất là khó cải thiện, đúng không? Cả về cấu trúc cũng như là cả về màu sắc. Thì chúng ta cũng rất mong chờ một cái giải pháp nào đấy mà cải thiện được sẹo, là một cái mà tất cả các bác sĩ da liễu chúng ta đều rất mong chờ. Thì trong nghiên cứu này cho thấy là PN đường tiêm là cải thiện được cả về mặt cấu trúc và mặt sắc tố của cái sẹo. Đây là sẹo bỏng rất là tốt. Thì đây là những cái nghiên cứu mang tính chất là các nghiên cứu số lượng mẫu không nhiều, cho nên chúng ta ở cái mức là chúng ta tham khảo thôi. Thế còn chúng ta sẽ cần thêm các cái nghiên cứu chi tiết hơn, sâu hơn để chúng ta có thể đưa ra được các cái kết luận. Về xu hướng của thẩm mỹ thì ngoài cái câu chuyện của trung bì thì cái thượng bì cũng rất là quan trọng. Thượng bì rất quan trọng. Đó là cái hàng rào bảo vệ da của chúng ta. Nó là hàng rào bảo vệ. Dù chúng ta cứ tập trung vào cái trung bì đến mấy đi chăng nữa, nhưng nếu cái hàng rào bảo vệ sinh lý của chúng ta nó không đảm bảo thì cái quá trình lão hóa, quá trình tổn thương của da do tác động từ yếu tố bên ngoài cũng là một vấn đề mà chúng ta có thể dẫn đến quá trình lão hóa hoặc tổn thương da một cách dễ dàng. Cho nên nếu chúng ta có một cái sản phẩm nào đó mà vừa cải thiện được trung bì lại vừa tăng cường được cái hàng rào bảo vệ của da là một trong những cái mà chúng ta rất là mong đợi. Thế thì trong cái nghiên cứu này thì người ta thấy rằng là cái PN và phối hợp với HA thì có tác dụng là cải thiện cái lượng filaggrin trên thượng bì, trên chuột. Thì đấy là những cái nghiên cứu ban đầu mang tính chất gợi mở. Thì về mặt xu hướng tương lai thì chúng ta đối với lĩnh vực thẩm mỹ và làm đẹp thì chúng ta không mấy khi một liệu pháp đơn thuần mà chúng ta có thể đạt được tất cả những cái kết quả liên quan đến chống lão hóa. Cho nên xu hướng của chúng ta sẽ là việc phối hợp giữa các cái giải pháp, bao gồm có sử dụng các cái dược chất các cái hoạt chất sinh học và kết hợp với các cái thiết bị phát năng lượng hoặc là phẫu thuật là cái xu hướng của tương lai. Và trong tương lai chúng ta hy vọng rằng ngoài các giải pháp thiết bị phát năng lượng, chúng ta có thêm các cái giải pháp bổ trợ làm tăng cường cái hiệu quả của các cái biện pháp xâm lấn tối thiểu đó. Và đấy là toàn bộ cái phần trình bày của tôi. Rất là cảm ơn cái sự chú ý lắng nghe của quý vị đồng nghiệp và các bạn.
Dạ vâng ạ, xin trân trọng cảm ơn bác sĩ Lượng về phần báo cáo rất là hấp dẫn và đầy đủ chi tiết. Tiếp theo, Dr. Kim sẽ trao đổi với chúng ta về chủ đề khai phá sản phẩm DOT polynucleotide của Rejuran, một công cụ độc đáo trong tiến trình phát triển của y học tái tạo. Trong phần báo cáo của bác sĩ Kim thì chúng ta sẽ có cái phần phiên dịch tự động. Các bạn sẽ để ý trong phần chat thì sẽ có hướng dẫn. Cái thứ hai là sẽ có phiên dịch viên sẽ phiên dịch cho chúng ta, và ở phần sau khi bác sĩ Kim trình bày thì sẽ có một cái phần gọi là tổng kết lại để chúng ta có thể tiện theo dõi. Next, it's my pleasure to introduce Dr. Michael Kim, who will be presenting on the topic unveiling DOT polynucleotides resolution, a unique tool in the evolution of regenerative medicine. Welcome, Dr. Kim. You may now share your screen and begin your presentation. Yeah.
Good afternoon, everyone. Can you hear me? Is it okay?
Yes.
Okay, good.
Clear. Yeah.
잠깐 화면을 안 켜도 괜찮겠나? 화면 안 켰는데.
화면 제가 세팅해놨었어요.
화면 켰어?
배경.
Michael Kim.
So sorry, just give us 1 minute. So sorry. Okay, I think we're ready to go. Hi everyone, my name is Dr. Michael Kim. I'm currently the Chief Medical Officer here at Pharma Research, and it's my honor to be here to be able to speak with you. I've been given about 20 minutes to talk about Rejuran. I can speak, hours on it, but 20 minutes is just a very short time, so I'm going to try and just reach some of the basic principles and theory behind Rejuran, because I think that a lot of the doctors, first of all, who have been using Rejuran know the clinical effect and have seen how it's helping them in their practice. But to understand it a little bit more and to get some more ideas about how to research it, I think is also important. And for those of you who have never used Rejuran before, hopefully this will give you a good foundation for you to build on to start to use Rejuran in your practice. I was honored to be in Ho Chi Minh City last year at the official launch of Rejuran, and it was a very short visit, so hopefully I'll be able to visit soon again and be able to spend more time in your lovely city. So let's go first into Rejuran, but I really think that Rejuran is becoming more popular and is being used more in doctors' offices because aesthetic medicine is evolving. And one of the things I think is evolving is in the way that we perceive aging. And up till now, a lot of times we've been talking about anti-aging. I use that a lot in my talks or also when I was in clinical practice in Singapore, I also use anti-aging. But if you really think about it, we can't stop aging. Aging is something that is natural. It will happen. Maybe we can slow it down, but we cannot totally stop it. And there are a lot of negative connotations also when we say anti-aging, like we have to stop it. And so when you see patients, cosmetic patients, that they will come and say, oh, doctor, I look so old, make me look 20 years younger. It's this type of mindset that leads to things like overfilled syndrome. And so maybe we have to have a more positive outlook on aging and maybe call it well aging, something that we embrace a little bit more, something that we will accept that we will age, but we will age a little bit more gracefully. And when we have this more accepting and positive outlook on aging, then treatments like PN will be more attractive and sought after. Okay, can you see? Okay, 보이지? 이거는 okay. Yeah, and the second part, I think, is the evolution to prevention. We talk a lot about rejuvenation, how we're trying to, like I said before, when patients come to us and they want to look younger, how we try and make them look, and we go back, rejuvenation, and go back, make them look younger. But if we just add one letter, then that becomes prejuvenation. And I think this is a very important concept that we need to maybe start to learn more about. And, more and more doctors are talking about how we need to prevent aging, slow down aging at an earlier stage. And I think that is very important. And so even for younger patients, Rejuran is not for those patients who are in their 40s and 50s or older, but even for patients, in their mid to late 20s when we know aging starts. If we start to use Rejuran at an early age, we can slow down their aging process and still have natural results, unlike fillers. And bringing it to my third point now, I think many of you realize that more and more patients and even doctors are moving away from volume replacing fillers. We talked about skin quality and how we have to change our paradigm to emphasize more about skin quality. And I think we all accept that now. And we all understand the problems with overfill syndrome. We see that a lot around us. And so I think we realize that to a certain extent. If we look at this, I don't know if you know what this is actually how pilots train before they go out in the airplane. And as they spin, there's G-force pulling down on their face. So I'll show you this example of this pilot. She's a very young pilot. If you look up here, this is the G-forces increasing over the few seconds. You can see how her face is changing. Now, if we look at her now, yeah, that's probably what she'll look like when she's 50 or 60 years old. This is how she originally looked like. Okay, so this is what she originally looked like. And now in that few seconds when gravity is pulling down on her face, we see how she will age and look in the future. And also here, if we look at this pilot, she looks like she's very old also with the G-force pulling down. But if we see in a second, when the G-forces are released, you can see how young she is already. So in those few seconds, did any of these two pilots lose any volume? Did they lose fat? Okay, but when we go to many seminars or we go to conferences, what we're told is that a lot of the causes of aging is due to volume loss or volume depletion. And so we have to replace that volume. But if we look at what we just saw here, if maybe the majority of the appearances and phenomena we see with aging is due to the laxity of the tissue and the gravity pulling down on it, maybe we need to go more into bioregenerative and EBD treatments like Rejuran. Okay, and there's also papers, this paper came out from Australia showing that fillers don't dissolve in 1.5 or 2 years like we are told or that we tell our patients. But we don't do MRI for all of our patients that we do fillers, right? But even in this paper, it showed that a patient who didn't do fillers for 12 years, she had fillers still remaining in her face. So they are remaining longer, and that's why we see these delayed inflammatory reactions, DIRs, many years after they've done fillers because they're still remaining in the face. And the last evolution, I think, is towards cold and regenerative modalities. I think I've showed this before, but traditionally we focus a lot on thermal energy like IPL, lasers, radio frequency, ultrasound, HIFU. We still do that right now, but a lot of that is not so ideal for patients with an active lifestyle who are, exercising, getting sun exposure. This is ideal for lighter skinned patients, Caucasians. But here in I'm not in Southeast Asia, but in Southeast Asia, where you are, and in Asia where I am, we have Fitzpatrick type 4 and 5, and the risk of PIH is much higher. So treatments like polynomial polynucleotides, skin boosters, exosomes, PRP. The professor just before me explained that very well. These type of regenerative treatments are becoming more popular, and it doesn't matter if you're active outside in the sun or what type your skin type is, and there's additional effects that we can see with these regenerative treatments. Now, when it comes to skin boosters, non-HA skin boosters, I think this is becoming more popular as time goes on, but we need to sort of set a different type of classification. We know about PLLA, CAHA, PCL, are coming out now too, and we term these biostimulatory, but a lot of them can be inflammatory. They work through the macrophage and inflammatory pathway. Unfortunately, sometimes this can lead to granuloma or even fibrosis. So, but on the other hand, regenerative products like polynucleotides, PRP, PDR, and exosomes, these are anti-inflammatory. And because they're anti-inflammatory, there's very, very little risk for that to produce granuloma or fibrosis, which is very important, even down the line, if we're going to do a facelift, which I'm not against, and, some patients might need that down the line, and even I might need that, you might need that. We don't want to have fibrosis and granuloma, when the surgeon goes in to do the facelift. And of course, for biostimulatory products, they're mainly synthetic, whereas many of the regenerative ones are natural, such as Rejuran. So to summarize, having aging, a positive outlook on aging, starting earlier in the patient's journey for aging gracefully, less filler-centric, and focusing more on regenerative products. So I think this is the evolution that we're going through. And if we just add one letter, that becomes a revolution. And it really does change a lot, because a lot of our practices have been based on toxin and fillers, whereas we're going more now into regenerative medicine. I really think Rejuran is leading that revolution. Now, our Rejuran is based on DNA fragment optimizing technology, or DOT. This is our proprietary technology, and using that technology, we are able to produce different types of pharmaceutical drugs, medical devices, and also cosmetics. It's threefold. First is the salmon selection and processing. Second is the fractionation of the DNA to appropriate fragments, and the production of the final products. First of all, for the salmon, we use Okita and also wild fish. And this, we don't farm or harvest the fish by ourselves, but this is actually done in collaboration with the Korean government. There's a Korean fisheries agency, and they are harvesting the fish, the salmon anyways, for their own use, and they were discarding the testes, and that's where we also extract our Rejuran. And this is what the chum salmon looks like on the left here. There are other products on the market. A lot of them use the rainbow trout. That's a different species than the chum salmon that we use. The scientific name is the Omycus. And we also harvest, as I told you earlier, from the wild. They are not farmed, and there are many other companies that farm their salmon. And the Korean salmon actually start in Korea, and after they are grown and they are released, they go all the way to America and Canada and come back. So that's a very, very long journey for them. Whereas the Japanese or the American salmon have a shorter journey in the ocean. And this is this river here on the bottom. If you come to Korea, you'll be able to see this. This is the river where they come back to spawn again. And this is where they are collected in the tanks. And at the Pharma Research Global Symposium, which is held every year in the autumn, you're able to go inside and also touch and catch some of the fish just to see for yourself. They take an average of 3 years to return, and only 0.3% return. So those that do return are really the champion, the most fit of those that have been released. The second part is fractionation of the appropriate DNA fragments. Many companies will claim to have polynucleotides, but if we look at this graph here, so the molecular weight is larger on this side. So our Rejuran PN, as you see, is located mainly here, whereas many of the competitors, they claim that they're polynucleotides, but their molecular weight fragments are mainly in the PDRN range. So being able to control that fractionation and molecular weight is also an important technology. And of course, finally, is the production of the final products. This is our company and the factories that we have. We are all very compliant to the regulations. We have KFDA approval. Unfortunately, there are products that are made in Korea, do not get KFDA, but are exported to other countries like Vietnam. And unfortunately, there are doctors who will bring over products that are not KFD approved and used, but that is a very big risk because of safety compliance issues that they have not been through. We also have CE/MDR and of course GMP certificates for our product. Surfactants are something that can be a cause for delayed allergic reactions. For our product, we have no surfactant detection. This was a doctor who injected herself with another competitor, another PM product, and showed that it took her almost 2 weeks for the wheels to heal because of maybe some impurities, whereas she used Rejuran many times before and said that she only healed within 2 days. So we can see that depending on the product and the purity, it can affect the healing time. So maybe in Vietnam, you might also have different PM products, so if you've heard of them, you might say, what's the main difference? And just like I explained, the raw fish source, the equipment, the facilities, the processes are important, but also the experience. Each process, each step is very, very delicate. And those minute details and quality control all are things that we have acquired over time. And that experience is what leads to the high quality product that we're able to produce to you. So let's go into PDR and PN a little bit more, just to be a little bit more clear. Polynucleotides are what we term the injectable medical device, which you have. There's also PDR, which are shorter fragments. Those are in the skin booster or in the cosmeceuticals. I think we all remember, the DNA molecular structure, which are a chain of nucleotides. And these chains of nucleotides are usually in a double-stranded form inside Rejuran. But unfortunately, there's no international or textbook consensus on the precise definition of PDR and MPN. So when we ask, what is the difference, it's still very flexible. Depending on who you talk to in the company or the doctor you talk to, there can be some difference there, but I'll explain to you from my point of view what it is. So PDRN is mainly extracted from the sperm, whereas polynucleotide is mainly extracted from the testes. The average molecular weight is longer in the polynucleotide, and of course, that will mean the nucleotide content is higher. And one major difference between the PDR and PN is the 3D scaffold structure, which I'll be showing to you a little bit later. There are many good review papers now on PDRN. This is really the basis and really where the foundation of Rejuran came from. It's from PDRN, so it's good to know a little bit about PDRN. So if you look up this review paper, you'll be able to catch up on the research that's been done on PDRN. And now, because polynucleotides are so popular, there are more papers coming out on PN too. But there are some content in there which I'm not totally in agreement with, but still it will help you give a little bit of a review. So what about the mechanism? But we have to divide the mechanism between PDRN and PN. So let's go into PDRN first. The PDRN mechanism is working as an A2A receptor, adenosine A2A receptor agonist. And through that is able to modify and regulate the cytokines to work in an anti-inflammatory way, also to increase the VEGF for angiogenesis. And also it will help to increase the growth factors for stimulation of the fibroblasts. Another is the salvage pathway, which I'll explain a little bit later. So if you know the A2A receptor is very important in cellular proliferation and tissue repair. A lot of the papers originated in healing wounds, in diabetic foot ulcers, skin grafts, corneal wounds, and also burns. So that's really where the basis of this type of regenerative medicine came from. For the salvage pathway, this is Boya. Okay, so for the salvage pathway, this was an in vitro study done where they added PDRN to cells that were damaged by ultraviolet light. So they produce these dimers, which are cross-linked between the DNA, which will obstruct replication and transcription, whereas P53 proteins are able to help to remove the CPD. So when they see the results, they saw that those cells that were treated with PDRN actually had lower CPDs and higher P53. So showing that the addition of PDRN can help to reverse or repair that ultraviolet damage in the cells, which I think is very promising. Also, mitochondrial biogenesis is something that we found when PDRN was added to certain cells, that it was able to increase the mitochondrial density, mTDNA gene expression. We know that this is very important in areas such as inflammation. We know that inflammation is a very large part of inflammation, and so if we can increase the mitochondrial density, then we're able to slow down that inflammation in the body for well aging. Also, there are papers on PDRN and how it works in terms of reducing pigmentations, but we don't have a lot of time to go through that. So if you have time, you can look up these papers. And even a very interesting paper about how PDRN can help to induce white to brown adipose differentiation. And as you know, it is important to have more brown adipose cells for reducing obesity. So maybe in the future that this will be an area that we'll be able to go into also. Okay, and in Korea, we have a product called Interdot. This is an edible gel type PDRN, but of course, we don't claim that this is for obesity treatment, but in the future, I think this is leading to that direction. Now, what about polynucleotides? If we look at polynucleotides compared to PDRN, it's a more gel form. And as I explained earlier, there is this scaffold structure. So what is that scaffold structure in more detail? If we do a cryo SEM, we're able to see that in the PDRN, there's not much scaffold structure there, whereas in the PN, there's a very particular, unique polygonal type of cell formation scaffold that we can see on the right. And under different types of magnification, you can see what it looks like, and it's a very unique type of configuration, something that we don't see a lot in other types of products that we use on the market. I was able to publish this, so also this is open access online. You're able to find this paper and read about it more. So if we look at the other common PLLA, PCL, the PDLLA, they're mainly spherical forms, whereas again, the polynucleotide is in a more honeycomb-like scaffold structure. So there is no side by side. We can't say which one is better, but still it's a very important difference that I think we need to pay attention to. And this is a recent confocal microscope image. The SEM, it has its limitations because it has to be frozen before we're able to see the images, whereas this was taken in the hydrogel state, so the state that we injected. And we can see inside the little parts where the fluorescent dye has been taken up by the polynucleotide. So even it's only 2% polynucleotide, we can see that there is significant structures within this area that can act as a scaffold. So I think polynucleotide works as a scaffolding framework, as a structural and functional extracellular matrix scaffold. And when we inject the Rejuran into the dermis, then what does it do? It will help to increase the viscosity or the rigidity or stiffness of that area. And how does that affect the body? Let's go into that a little bit. First of all, it can help with mechanotransduction. We know that cells, they attach to different points inside the ECM, especially the collagen. If we look here on the left, this is a very popular paper. A young patient, older patient, the younger patient fibroblast is stretched, enlarged. The collagen is robust. We can see that there are connections. It will produce collagen. That's where we get the youthful appearance. In the older patient, the fibroblast has shrunken. And you can see that the collagen around it in ECM is all degraded. It's all broken up like you break up spaghetti. And so there's no attachment points. And so once that happens, the cells become senescent and they stop to produce collagen. So not only that, we know that they produce pro-inflammatory cytokines. So they're not only senescent, but they're also accelerating aging in that state. But this important paper, what it did show is that when they took a senescent fibroblast and put it into an ECM of a young patient, representing a young patient, that it actually regained its functionality. So what we're proposing and hoping is that as we produce this scaffold structure into the ECM, even though older patients might have senescent fibroblasts, producing that scaffold for it to attach to again, it will be able to re-stretch, regain its functionality. Secondly is mechanosensation. We know cells move in different directions, and so one of that can be durotaxis, because cells will move towards a more stiffer gradient, and according to this paper, we can see it moving from a soft area to a more stiffer area. So when we inject Rejuran, we're hoping the fibroblasts will move into this area. Thirdly, stem cell differentiation. According to this paper, stem cells will be stimulated according to the ECM stiffness, and so when we increase the stiffness, we can stimulate these stem cells through that. And also when we inject Rejuran, where do we inject it? We inject it into the intradermal area, which is around this area, and there's a very indiscrete border between the dermis and the subcutaneous layer. So some of that will go down into that layer. And in this paper by Krugelkopf, it did show that the interface between the dermis and the subcutaneous layer was the most important part that was correlated to aging. And also in this paper from Japan, what they did is check the viscoelasticity, and they divided the dermis into 2 sections and also the subcutaneous into 5 sections. And what they found is that it was the lower part of the dermis and the upper part of the subcutaneous layer that was the most important in correlated for aging. So in summary, we know that the PDRN has these types of A2A agonists and other mechanisms, but for the Rejuran PN, I think it's incorrect to say that it is working in this area and has not been proven to do that either. I think it's through the scaffold and increasing the ECM rigidity through what I just explained. Of course, some might be degraded by DNAs in the body into smaller fragments and have some overlapping, but this is still something we need more research on. So for the subtypes of Rejuran, there are 4 types, as you know. The main difference is between the viscosity. The lowest viscosity is HB+, then I, then healer, and then S. And I think this is important in terms of that scaffold that I just showed you before. And I wanted to see the difference on the salmon. What we can see here is that the Rejuran HB+ and I, which are lower viscosity, have a very more less dense type of scaffold. The walls are also thinner compared to, for example, the Rejuran S, which you can see has a more dense scaffold and also thicker walls. So the indications for polynucleotides are very diverse, even including eczema, dermatitis, and alopecia as we move forward. There's even this paper that we show that a lot of doctors in Korea are using it for facial erythema. This Rejuran healer is in a 2 cc syringe. So it's very applicable and helpful for pore size, skin thickness, skin tone, melanin reduction, wrinkles, and sagging. The Rejuran I is meant for the periorbital area, and this one is in a 1 cc syringe. This paper shown earlier is a randomized double-blind split phase compared to non-cross-linked HA on the other side, and it did show that the PN side was more beneficial on the hydration, elasticity, roughness, pore volume, and other areas. For the Rejuran S, this is mainly, the S was marketed and explained mainly as SCAR, but in my opinion, I think S stands for special because it is more viscous. I think there are some regenerative advantages of using S, especially in thicker skin that you might see in your country, Southeast Asia. You know, I was in Singapore for 20 years too, but in those patients maybe that healer was not as effective, you might consider using S. And it's not just for scars, but also to use it for your regenerative patients, for regeneration in your patients. This paper was a post-thyroidectomy scar paper in 44 patients, and this one you can look up also, showing improvement in the scar, in the erythema index, and the patient satisfaction. So in acne scars, this is how I usually inject. I inject inside of the scars, but also underneath the scar here for regeneration there too. So Rejuran is very versatile because of its high safety profile. It's also, you might not inject necessarily intradermally, which is okay. Even in the subcutaneous layer, we find that there are similar beneficial effects. You can also use it in combination with various EBDs. It's stable under high temperature, but we do recommend usually to do the laser EBD before Rejuran. Do not mix it with cross-linked HA or non-approved products like exosomes. We've seen some cases where doctors mix it with exosomes, inject it, and find that there are some nodules forming, and this is not due to the Rejuran, but of course we all know that exosomes are still not approved for injection. I mentioned earlier about how Rejuran is stable at 70 degrees Celsius, so it's heat stable to use in combination with EBDs. If you do choose to mix Rejuran with other products, for example, non-cross-linked HA, there are various different recipes that you can use. This is just my personal one, but non-cross-linked HA toxin, lidocaine can do. But when you do mix it, try and be gentle. If the scaffold, we agree that it's important, we don't want to damage the scaffold as we're mixing it too vigorously. Safety-wise, 15 million syringes used in more than 30 countries. There's still no reported case of vascular compromise to date, so you can rest assured, even though you're injecting 2 cc's, 4 cc's, 10 cc's, still there is no officially reported case of vascular compromise. And also there was this internal research that we did. We injected lightly crossing HA intravascularly to the rabbit ear. And of course, we found that there was necrosis, whereas on the side where we injected Rejuran I intravascularly, there was no necrosis. Side effects are just the basic ones that we do see with other skin boosters: pain, erythema, some swelling is possible there. This is a very common post-injection reaction to have a bit of redness. If it's a little bit more severe than you expected, you can always prescribe maybe a hydrocortisone 1%, antihistamine. Usually it'll resolve within 2 to 3 days, normally within 2 days, but for those more sensitive patients, it might last about 3-4 days. But you also have to wonder and consider and assess what type of anesthetic agent did you use. Does the patient have some allergy to that numbing cream? Did you use alcohol, which maybe the patient is sensitive to? These are some things that we need to consider. So finishing now, practical application for numbing cream. We all know pain is an issue for Rejuran. So I do use a compound numbing cream of benzocaine, lidocaine, and tetracaine for about 40 to 45 minutes. You can use cooling together. Using a vibrator to distract the patient or mix with lidocaine is also possible. I personally prefer to use chlorhexidine on the patient, but we know that it's toxic to the eye, so be careful that it doesn't splash in the eye and that the patient has the eye closed if you're using chlorhexidine. So the basic protocol is 3 sessions, 4 weeks apart. We do know that it's dose dependent, so the more that you use, you'll see better effect. Intradermally and serial puncture. 6 months later, you can do 1 session as a maintenance, but there are some patients that want to do it monthly. And according to this, 1 cycle about every year is something that we recommend. So if you're injecting for the first time intradermally, you can use this guideline. So we know that the needle of the Rejuran needle is 4 mm. So if you just use half of it, 2 mm, and you're at a 30-degree angle, you will be at about 1 millimeter. And according to different papers like Chopra, we know that this will be enough in intradermal area. But if you're in thinner Caucasian skin or in periorbital areas where the skin is thinner, still halfway, but you can just lower the needle angle to about 15 degrees and you'll still be within that intradermal area. The needle inside the package is different. The inner diameter is bigger and the wall is thinner, so that allows easier injection compared to other ones on the market. It's made by JBP in Japan, and it also dulls faster. So after 1 cc, I recommend to change it. This is how I inject with my hands. It's important to use your non-dominant hand to have good traction on the skin and also to stabilize the syringe if you want accurate intradermal injection. So this is a video of me injecting intradermal. You can see I'm not even half of the needle. It's only maybe 1/3. You can see the wheel forming. It decides about 4 millimeters in diameter. This is another close-up of me injecting. You can see the wheel forming. There's not much leakage here. Okay. And finished with that one. This would be too superficial, of course, if you do that. If you're too deep, this will look, and you will see here, you can see the wheel, but here, no wheel, right? Because that means that you're in the subcutaneous layer. So immediate post-injection, and usually by the second day, it will resolve. This is just a video just to show you in real time, usually how long it takes. If you're faster than this, injecting faster than this, you're saying, oh, I can inject faster, but then you're most likely in the subcutaneous layer, because it does take time because of the resistance in the intradermal layer. Okay, this is what it looks immediately post-injection. 어디 갔지? 어디 갔어? 늦었어 그런가? Oh, so sorry. I think there's some delay in the slides. Okay, are we good? Oh, this is really slow. Okay, I think we're good. Yeah, for the periorbital area, we can use 0.5 cc per side. Usually maximum about 1 cc per side is what I use for Rejuran eye around the area.
Around the area.
Okay, this is not, okay. So sorry everyone for this technical difficulty. So sorry, give us a minute, please. Okay, so we're working. So I think the video might not be working, but this is me also injecting supraorbital on the upper eyelid. You can inject, but it's a more advanced technique. So I recommend after you have more practice to use that for the upper eyelid. It's not working. because the video, I think, is not working. So 이게 그냥 중단하고 그 다음에 나중에 끝에 다시 할까? 좀 정리하고.
네.
So sorry. Would it be okay to maybe go on to the next speaker? We will maybe have to reboot the computer, and I can finish maybe at the end. Is that okay?
Giờ qua từ cuối.
Yeah.
Yeah. So many thanks for your sharing, Dr. Kim. Yeah, we learn so much information from your presentation. So tiếp theo để khép lại phiên khoa học ngày hôm nay thì thạc sĩ bác sĩ Thái Thị Diệu Vân sẽ trao đổi với chúng ta về chủ đề tôi xin lỗi một chút là ở phía sau bài trình bày của bác sĩ Kim thì sẽ có cái phần recap lại của phiên dịch viên ạ. Xin mời phiên dịch viên ạ.
Dạ, xin chào các quý vị bác sĩ, xin chào các bác sĩ chủ tọa, các bác giáo viên cũng như là các bác sĩ tham dự webinar ngày hôm nay ạ. Thì em xin phép được recap lại một số nội dung chính mà bác sĩ Kim ngày hôm nay đã trình bày. Thì bài của bác sĩ Kim sẽ tương đối dài và giải thích rất là nhiều cơ chế khác nhau. Tuy nhiên thì em xin phép được recap lại một số nội dung chính ạ. Về thứ nhất đó là về PN cũng như là về nguồn gốc của PN của Rejuran. Thì đối với Rejuran thì họ sử dụng công nghệ DOT là một công nghệ là tối ưu hóa đoạn DNA, và đây là một công nghệ độc quyền của Pharma Research nhằm để chiết xuất được PN, PDIN tinh khiết từ cá hồi hoang dã và từ đó để ứng dụng trong sản xuất thuốc, các sản phẩm tiêm cũng như là dược mỹ phẩm. Và tại Rejuran thì tất cả những cái sản phẩm mà được phép tiêm là đều là những cái sản phẩm chứa PN, còn các sản phẩm mà chứa PDIN, chứa cPDIN thì đều được ứng dụng dưới dạng là bôi thoa và dược mỹ phẩm. Vậy thì công nghệ DOT là gì? Thì công nghệ DOT ở đây nó là một cái công nghệ mà tối ưu các đoạn DNA. Thì cái công nghệ DOT này nó sẽ bao gồm thứ nhất đó là việc lựa chọn và chế biến cái nguồn cá hồi hoang dã giống như trong video khi nãy và những cái hình ảnh khi nãy mà ông Kim có share đấy ạ. Thứ hai là họ sẽ phân đoạn các đoạn DNA và tạo ra những cái đoạn DNA tối ưu hóa và phù hợp nhất để sử dụng ở trong cái sản xuất những cái sản phẩm. Và thứ ba đó là tạo ra những cái sản phẩm cuối cùng mà chúng ta sử dụng. Thì tất cả các công nghệ này được sử dụng, tất cả những cái quy trình này đều được sử dụng thì đều là cái công nghệ độc quyền và đã được cấp bằng sáng chế. Thì các đoạn DNA này thì đều được sản xuất theo công nghệ DOT và có cái khối lượng phân tử và cũng như là cái đặc tính lưu biến độc quyền riêng biệt để tạo ra những cái kết quả lâm sàng và độ an toàn tối ưu. Các cái sản phẩm .pn của Rejuran thì đều đã được đều đạt được những cái tiêu chuẩn của KFDA, có giấy phép trang thiết bị y tế của châu Âu, có chứng nhận GMP cũng như là giấy phép trang thiết bị y tế loại D tại Việt Nam. Ở phần của ông Kim thì ông sẽ nói rất nhiều về PN và PDIN và ông giải thích rất nhiều cơ chế. Vậy thì tóm lại sự khác nhau giữa PN và PDIN nó như thế nào? Về bản chất của PN và PDIN thì đều là những cái đoạn DNA, đều là những cái chuỗi polymer được tạo ra từ những cái nucleotide. Và trên thực tế thì không có một sự đồng thuận quốc tế hoặc là được ghi ở trong sách giáo khoa nào về cái sự khác biệt chính xác giữa PN và PDIN. Tuy nhiên thì tại Pharma Research thì họ sẽ tạo ra PDIN và PN với cái sự khác nhau và họ sẽ đặt ra những cái tiêu chuẩn chất lượng rõ ràng để chúng ta phân biệt hai cái thành phần PN và PDIN của Pharma Research. Cụ thể đó là PDIN thì sẽ có nguồn gốc từ tinh trùng cá hồi, trong khi đó thì PN sẽ có nguồn gốc từ tinh hoàn cá hồi. Kích thước của của PDIN sẽ ngắn hơn, do đó nó sẽ mang lại cái tác động nhanh và cấp tính trên da. Còn PN thì cái kích thước của nó sẽ dài hơn và mang lại cái hiệu quả tái tạo, cũng như là họ sẽ polymer hóa để tạo thành cái cấu trúc giàn giáo 3D scaffold mà khi nãy bác Lượng cũng nói đến rất là nhiều về cái vai trò của nó đấy ạ. Tiếp theo đó là về trọng lượng phân tử, thì đối với PDIN nó sẽ có cái trọng lượng phân tử thấp hơn là khoảng 350 kDa, trong đó PN thì khoảng 1.000 kDa. Về số lượng, về cái lượng nucleotide ở trong mỗi cái thành phần thì về PN nó sẽ gấp tầm khoảng 10 lần cái lượng PDIN ở trong sản phẩm. Và có một đặc điểm rất là đặc biệt, đó là PN nó sẽ có cái cấu trúc giàn giáo tạo nên cái sự khác biệt về cơ chế hoạt động và nó có cái đặc tính vật lý và nó sẽ khác so với PDIN. Vậy thì cụ thể về cơ chế hoạt động thì PN ấy, thì người ta sẽ tập trung về cái cơ chế, về cái tác động sinh học của nó hơn. Trong khi đó thì PN vừa có tác động sinh học của PDRN và vừa có tác động vật lý. Bởi vì khi mà chúng ta sử dụng vào trong da thì khi mà tiêm vào trong da nó sẽ tạo nên cái tác động vật lý đầu tiên nhờ cái cấu trúc giàn giáo 3D scaffold, nhưng mà nó sẽ bị phân giải từ từ ở trên da của mình, tạo ra những cái đoạn PDRN. Do đó thì PN nó vừa có tác động sinh học giống như là PDRN, đồng thời là nó có cái tác động vật lý nhờ vào cái việc là nó có cái cấu trúc 3D scaffold. Dạ, vậy thì tóm lại thì dot PN của Rejuran thì sẽ có đồng thời hai cơ chế tác động, đó là tác động sinh học. Thứ nhất là nó sẽ thông qua